because the unregulated fibers, which transmit pain are blocked first. You may have lots of pain in the leg, but pressure will be there. Okay? This is an OPG of the case. Okay? It is one of the most difficult things to do. Okay? Pre-operatively, a few things you should see. First is the mouth opening of the patient. Make sure that the patient has adequate mouth opening. Okay? In an X-ray, you can see a few things. Yes, patient's mouth opening is adequate. Okay? Then you see the thickness of his cheek. Is it pliable? Can we move the tissues? Yes, that is also seen. So, visibility, accessibility is there. Okay, then we go and see the OPG. Okay, so this is a horizontally impacted mandibular third molar. Okay, you have lots of classifications. Yeah, in parallel heredity classification, the highest point is at the occlusal level, and half the tooth is inside the ramus. So you can call it a position A, class 2. Okay. So here we will also have to see the relationship of the inferior alveolar nerve. Remember, inferior alveolar nerve. It is important to see always the relationship. In an OPG, you can see from where it starts. You can trace the inferior alveolar nerve at the level of the root of the third molar. Fine. Then also you have to see the ascending ramus, also an external oblique ridge of the patient. That shows you the external oblique ridge. Ascending ramus comes down up to the first molar as the external oblique ridge. So you can, when you see the cases, always know that MPGs, the external oblique ridge, because the external oblique ridge, it is going to be more difficult to extract the tooth. Okay? Can we go to the procedure? Okay? So, the instrument, always make sure you arrange it in order. So, while doing that case, you are not apprehensive, you are relaxed. You know where the instruments are, it's not haphazard. It is easier as a beginner to follow a clean and clear procedure. Okay. So, you have the Austin's reflector, the right angle reflector to reflect the soft tissue and the flap. This is the number 3 and number 7. They are the two BB blade handles that you have.
Just exposing the impacted teeth. Just I want to show the impacted teeth. You can see this. This is an horizontal type as discussed by.
The tooth is not.
You can see a partial crown here. This is horizontal. The distal part of the crown is clearly visible. Okay.
Little more focus. Camera should come from up. Little more.
Yeah, this is visible, sir. Yeah.
Yes. A little motion inside the mouth, yes sir.
Yeah. So we can see the distal aspect of the crown here. Okay, this is an horizontally impacted teeth with position A. The highest point of the impacted teeth is at the level of the occlusal plane. So the procedure is like this. We are going to start the surgical procedure. It has got few steps. One step is just to make an incision. Okay, the incision. And second thing is the mucoperiosteal flap. Both the incision and mucoperiosteal flap is to elevate the mucosa and periosteum to expose the impacted teeth, so that it can be helpful for tooth removal and for bone removal and tooth removal. So next procedure will be after the elevation of mucoperiosteal flap with full thickness mucoperiosteum. And second procedure, third procedure will be just a bone guttering procedure. That is nothing but removal of bone around the impacted teeth and to create a trough for application of instruments and for elevation and for tooth sectioning. Once the next procedure is, once the trough and bone guttering is done, the next procedure is suctioning the roots. It depends on the impacted difficulties, we suction the roots to minimize the amount of bone loss, to minimize the amount of bone removal for procedure. So once the tooth sectioning is done, the tooth is elevated either in a form of a crown or longitudinally split, or it may be in a form of a root or crowns to remove the teeth entirely from the socket. Once the tooth sectioning is made and the tooth is delivered from the socket, the complete inspection of the socket should be done to see if there is any injury or any perforation or any unusual hemorrhage. It has to be treated then followed by debridement, closure and post-operative instructions. Yes, sir?
Okay, sir.
Yeah.
Take it over. Okay, so sir is going to use this, sir, horizontal tool. Yes, sir. Continue.
Sir, since it is an horizontally impacted teeth, what incision is I'm going to use an modified was incision, sir. The reason is it needs the amount of bone removal is slightly required in this case for application of the elevators. So just I am applying the cheek retractor for better visualization, sir. Just a minute.
Okay. So there are various flaps to use. Okay. The most commonly used is a what or a modified what. Okay. That is the anterior descending limb. Okay. And a intermediate limb and a posterior limb. Always remember that you have to should not split the papilla. Okay. The papilla distal to 7, you should either include it in the incision. You try not to split the papilla. So, in a modified wards will be taken from the PCO-buccal line angle. Okay? The wards will be from the disto-buccal line angle. And you do not sever the papilla. So, the anterior releasing incision. You do not cross the attached gingiva. Okay? You do not go to the free mucosa while making the anterior releasing incision. Okay? You have a lot of bleeding if you cross the attached gingiva.
Basically, the incision starts from as explained. It's a modified incision on the mesial-buccal, disto-buccal line angle of the first molar. Yes? Yeah.
Yes, sir. Visible, sir. So, it should be towards you. Okay? While making the incision, it should be towards you. Also, hold it in a pen or a modified. Hold the handle in a pen grasp or a modified pen grasp. Okay? Because as beginner, you should not slip, you should not damage any tissue. It will start all of us at a little handshake and all in the beginning. Yeah? But always remember, yeah? Show confidence in front of the patient. Do it slowly with a proper technique and proper grasp. Usually it takes a really minute. Okay? So he is using the knife and pulling it towards him. Okay? So there is a chance for him to slip and go. Okay? Doing in the opposite way, you slip, you go down and touch some other structure. Fine? Then you make the incision through the sulcus. Yeah? You split the papilla, you respect the entire papilla, and you make the distal releasing incision through the external object. Not external, through the ascending ramus. Yeah? The incision should go up. Distal incision, it should be for 2 to 3 millimeters in bone. Okay? So the distal what you make, you should clean the bone distal to the second molar or distal to what is exposed from the third molar and go along the ascending ramus of the mandible. For around 3 to 4 millimeters, you go cleaning the bone. Okay, and little soft tissue release you give. Just slightly you just cut a little in the soft tissue. Okay, this will allow the flap to stretch more. Right? So this is the sulcus. Now he is using an elevator to open up the flap. He is using this pointed end to pry the interdental papilla off. After, can you see that? And this is a small distal release that he has given in the bone. So, make sure that the flap is a full thickness flap and you can reflect the periosteum as well. Okay? That will prevent bleeding. If you can see clear bone like this, you will see that there is very little bleeding there. Now we take the side of the hospital retractor to the hook end. Okay? So you place now the hook end on bone, not on soft tissue. The hook end should rest on the, like I said, ascending ramus. Okay? The hook end is on the ascending ramus. And it holds the tissue. Can you see the loss of blood? No bleeding at all. Next, now silence. After this, is reflecting the entire tissue. So, the distal surface of the bone, what is distal to the tooth is C. Okay, and you can then protect the lingual nerve. The lingual nerve is very close to the third molar. In the let us say class 2, class 3, there is a high chance that the lingual nerve can get affected. Okay, so you have to be careful and always use the instrument piercing to protect the lingual nerve. You can put it there like that, subperiosteal. Okay, and it will stay there most of the time. Okay, so this gives protection for the lingual nerve, which is very important. The patient is always going to be complaining of paresthesia of the tongue and here 2/3. Okay.
The nice, sir, no?
Continue.
Yeah. The mucoperiosteal flap is elevated. Okay, and the purpose of the mucoperiosteal flap is to expose the bone for better access for tooth sectioning, as I explained. Okay, before the mucoperiosteal flap is elevated, the impacted tooth is exposed now. Okay, so the exposure should be on the buccal side, on the distal side, because we need to cutter the bone both on the buccal side and on the distal side. On lingual side, the bone guttering should not be done. The most possible bone guttering procedure what we follow is the Moore and Gilbey's collar technique. Okay, this is the one where we remove the buccal bone and the distal aspect of the bone. Lingual side, the bone guttering is not done because of more injury to the lingual nerve. Okay, that is very important, because according to Kesherbach and Chamberlain, it says that lingual nerve lies at 2 millimeters inferior to the crest of the lingual crest, and 0.5 to 3.5 mm on to the lateral to the lingual cortex. So the no bone guttering is performed on the lingual aspect in order to avoid injury to the lingual nerve. Yes, sir? Right?
Yes, sir. Thank you, sir. Okay, sir, is going to use a burr. Yeah, there are burr and handspring can be used, or a chisel and mallet. Yeah, it is preferable to use burr. It is more comfortable for the dentist. It is less painful or stressful for the patient as well. Both have their own advantages and disadvantages, but nowadays the burr technique is used. Like sir said, finally it's called the Moore-Gilbey collar technique. Okay? So sir will be creating a trough. You can use usually a 7-on-1 tapered fissure burr is used. You can use a round burr. Books even tell us you can use a round burr. We have to remove and expose the tooth. Here sir is going to use the burr, usually 7-on-2 or a 7-on-3 burr. Typically 7-on-1, 2 or 3 depends on the size of the burr. Okay,
so this is the cross-cut straight fissure burr 72. Okay, 702, and the length of the burr is 7 mm and the width is 1.5, that is your diameter is 1.5. Okay, so this is the burr, and the speed I am going to use it like 15,000 to 20,000 rpm. Okay, so it should not be exceeding, the bone guttering procedure should not exceed more than 47 degrees Celsius, because whenever I am using a burr for cutting the bone, it may causes a thermal necrosis. So I need a copious irrigation of saline to make it without producing any exothermic reactions or exothermic heat. Okay, so that's very important.
Okay. Okay, so you are going to cut this, sir?
Yeah, I'm going to start guttering.
Okay, sir.
So the guttering starts on the buccal aspect and it slowly goes to the distal aspect.
Okay, sir. So sir is starting with buccal gutted. Okay, so forming a trough around the tooth. So he will be creating a trough buccally and also distally. The amount of bone to be removed, usually it is up to, even initially if you are planning to put a minor operation where it is going to be, sometimes we will remove bone up to the cement enamel junction. Okay? Or if you are sticking a tooth, you may have to remove bone up to where you see the perforation of the tooth. Okay? Also, Then something was a distal spur of bone that has to be removed when injection. Okay? You have to keep the handpiece parallel to the two. If it's a second molar, if it's a horizontal tooth, it should be bottom parallel. So good flap is very essential. See, there is good accessibility for the two, visibility is also good. Okay, and there is very little bleeding that is present. So you use usually saline has to be copiously irrigated. Saline irrigation and wetting of the bone. Now surgery after wetting of the bone, you have to wet up to the marrow. Okay. You will wet up to the marrow. Once you enter the marrow stage, you will start feeling bleeding. Okay? You can either totally run the handpiece like how you are running it. You keep running it in a continuous motion. Or you can put certain, like postage stamps, you can put certain words, holes and characters. Okay? In the starting case, you can even put word holes. So, it will give you more control over the procedure. So the entire tooth of the crown of the tooth will be exposed. Patient is free of pain after entering the marrow. So good anesthetic, good block is necessary. Lots of times you see most of the doctors go to the narrow space, sometimes they take it to the doctor. So that is the anesthesia. Make sure you have good suctioning, okay? Good suctioning is needed so the visibility is there always for us. Yeah? Can you see the bleeding now from the marrow? You can slowly do the procedure, yeah? Slowly as you come forward, sometimes you can damage the second molar. Do a little division, slowly keep moving forward. You will experience one or two days, you will learn how to stop, like to stop, okay? So the body everything is done. Now, the distal everything is going on. The use of the instrument or the reverse surgery, sometimes even if you go to the market, you will hit on the instrument. Okay? You will not damage the reverse one. The exercise, it can be up to 2 millimeters median to the reverse crest of bone, and it can be at the height of the ridge, maybe slightly higher or lower. Okay? When you use the instrument, you will hear a small metal sound. So you know you are using the instrument and you can stop.
Hello sir?
Yes sir.
Yeah, the bone guttering has been done. The adequate amount of bone has been removed on the buccal side and the distal side. And the next procedure is, since you can see that brick bleeding is from the medullary part, okay? That is the, hello?
Not shake the camera.
Yeah, that is the limitation. You should not, you have to follow the course of the inferior alveolar nerve when you gutter on the buccal side, because it is usually shallow on the distal side. When it goes on the mesial side, it goes further deep. So it is very safe to make a minimal guttering on the distal side and more guttering on the mesial side, because your point of application for removal of horizontal tooth is mostly lies on the mesial aspect. Yeah. So since the adequate amount of bone has been removed, the next procedure will be the suctioning of the crown. So that will be the procedure. Suctioning of the crown for horizontal tooth is mostly to crown and root ratio. That is, make an vertical cut on the collar of the root or collar of the crown, so that you can split the crown, remove it, so that we can create enough space, so that the space created, we can just push the roots into the space and we can elevate it. That's the principle behind it. So what I'm going to do is, I'm going to make an oblique cut on the crown, so that exactly on the cervical line, slightly posterior to the root aspect and slightly anterior to the inferior aspect, but not on the lingual side. I'm going to gutter entire thing on the buccal side to avoid injury to the lingual nerve.
Okay. So sir, splitting the tooth part, okay? Splitting the crown, okay? Splitting of the tooth minimizes the amount of bone removal that we have to do. Sir, splitting it in a horizontal, like sir said, obliquely in a horizontal plane, okay? So from up to down is going to split. When you split, the top portion of the tooth, okay, or the crown that sir is splitting will be slightly larger than the lower portion of the tooth. Why is it? Sir will show you that, okay? Because if the bottom of the crown is larger than what is top, what will happen is the crown will get stuck. It won't come, okay? So the top portion will be little larger than what is below. That's why sir is splitting little obliquely. Always put lots of irrigation to it. Can you see the split now? Yeah, now it's clearly visible how sir is doing it also. Right? Usually we can leave the lingual stem of bone. Okay? Lingual enamel can be left before you do not do a full cut on the crown. Okay? You can leave a small lingual fragment and break it with the elevator. I think sir will show that also. You can always, if you during the initial stages, you can always see use the hand or to gauge the depth on an OB or an IOP. See how much rubber tooth can be cut. Okay, you can measure and then you can cut during the initial phase. Fine, it will give you more confidence that you do not damage the inferior alveolar nerve also. Okay, as you do more number of cases, you get a feel of how you are cutting. The bone will still look like the tooth will still look like. Yeah? Initially, you can measure it in the radiograph. go to the entire nucleus of the tooth that is starting. Okay? Always take your time while using the tool. Because there is a lot of tooth structure that has to be split. Okay? To learn how to remove one example, we need to remove any tooth. Good attention is required and the patient is still pre-operative. We take remember after anesthetic or it is around 1 hour anesthesia for the tooth. Okay? Always see the lingual nerve is protected. Okay? If you are not taking the tooth, you will not use the instrument like that. You can just remove the instrument out. Or by using the distance board remover, you can place the instrument as well.
Yeah, it is more like an oblique split, okay? The angulation is very important. So whenever my preference is I have given a broader cut on the upper side and narrower cut on the lower border, okay? So that's very important. So I'm going, once the adequate split is made, I'm going to just down fracture it. I'm going to split the crown alone.
Just place a millimeter length and rotate it slightly. After that, try to part of the crown outside. Okay? Slowly, naturally, without being in any hurry, take the part of the crown that we have cut. You can just some amount of movement in the tooth. What usually happens is sometimes a little amount of bone can be put in the tooth immediately. Okay? Any small part of bone or tooth bone in the tooth crack usually it will take a little time to run out. So invariably, it slowly make sure you have to relieve all the obstructions that are there. So now taking and seeing remaining bone. This bone is the crown back as well. So little more rapid further doing. Usually why we split the tooth because that is what is called as a tooth lock. Okay? Most of these initial or horizontal tooth, the crown is locked by the crown of the second molar tooth.
Sir, yeah. That's why that mesial crown is highly wedged below the cusp of the 7. Okay.
Yes.
So what I'm going to do is I'm going to further longitudinally split the crown. Okay. Still it resists the normal force and it's not be very easy to remove it. So I'm going to make a longitudinal cut on the crown. Okay. So that I'm going to remove the upper half and lower half.
So now further splitting the crown. Okay, so we take the crown out in 2 pieces. Fine. Always remember, it's not the excessive force. The tooth should be able to be updated with money force. If not, you will have to what procedure you are planning on. Okay, always you will have to think of what you are going to do if it doesn't come out the first plan level. Okay, before splitting the crown to make the removal of the tooth easier. So once the crown is removed, after this it becomes easier to remove what is left. Okay? So the part is lock. It's very hard to remove the lock. Sometimes it will come out. Sometimes the lock will, or the, like I said, the tooth lock, that the crown of the second molar is preventing the contour of the second molar, right, is preventing the crown from coming out. Sometimes it can happen. Yeah, this should be usually we should try to evaluate it in the course of experiment and be prepared that if it doesn't come out in the normal state, we are then going to cut the crown of the tooth. Let's see.
This is the superior part, distal aspect of the crown. Okay. Once this crown is removed, the inside part, the mesial aspect, which is wedged below the contour of the second molar, is clearly visible. Okay. So I'm just inspecting what happened, why it is difficult to remove it.
You still see the very limited amount of bleeding that is there. Okay, good accessibility and visibility. Okay, make sure that you can see. Do not remove what you cannot see. That is the most important thing. Okay, in any extraction, if you are raising the root stem, okay, and if you can if you cannot see it, do not try to remove it. Okay, always we should be able to visualize what we are going to do. So if you remove the upper part of the crown, you can see the mesial part of the crown that is there, and any remaining space that is needed, that is doing it now, and gaining more space so that the crown can be removed from it. Usually we do not give the specific time that we are going to remove within certain time. Okay? Always when you are having it looks easy also, some cases cannot or will not come out that easily. Okay? So always in the patient. Yes, this is the way we are going to do it. But if some other procedure or something happens where we may have to do it, change the procedure, may take a little more time. But okay, don't worry, I will look at it. To give the patient that confidence. Okay, while starting. Okay, so there are confidence when they initially. Okay, here you see initial response doesn't come out. Okay, you do not show consideration to the patient. Right? Updating all the group, the patient, the body data, and also the system testing. Sir,
Yeah, yes, sir.
what is the next step you are planning to do, sir?
This I'm just splitting, I'm just removing the wedged root which is crown which is present inside the
Yes. So what part of the crown left sir is removing that. Okay? Then slowly and to left it out. This is slightly moved. Still very comfortable. Is not having any pain or discomfort. So always evaluate the amount of loss that is there in a tool. Okay? The easy way is there is something called the arc of rotation, which while you are in the departments, when you see an IoT, you can try. Okay? From the distal root tip to the medial part of the crown tip, you draw an arc. Okay? You put the there is not how much doctor second molar is bisecting using. Okay? The more is bisect the second molar, it means there is a very big loss and you have to definitely split the crown. And you have to split the crown immediately. Okay? Like I said, this is the class 2 case. Okay, there is more amount of bone that you have to remove. Yes, we have a concentration channel gregory where class 2 is where half the tooth will be inside the veins of the mandible. Right?
Sharp used.
What usually when we do, you have to, that means everything is more slower because now we are in the deeper portion. Okay, we cannot gutter blindly and we cannot apply more force. Okay, one is more force can cause an unwanted factor, but more important, you can damage the exterior alveolar nerve, they are very aggressive here. Okay, so slowly you have to only slowly gutter and elevate the tooth. Here it is now one start teaching and when you are doing okay. Suction is very important. Okay, you will always in your assessment you give good suctioning. Okay, under suctioning is there, it is very hard to see inside. Okay, there will always be a little amount of blood that keeps coming. So you are doing that. Initially, you have to tell your assistant, yeah, to be very efficient, to try to cut as much as possible and give us good visibility. Sometimes it happens where the mesial bone is very hard. The mesial bone that is covering the tooth, the lower part of the crown, still may be slightly holding it intact. So it is important to try to get it from the mesial part of the bone that is holding the tooth. And there the platform, I think cannot do this, right? What is wrong? The steps in removing all infections is nearly the same. Okay, like this, that. Now, when there is a tooth lock, you have to always split like this. Either the crown root or divide it to a crown and root subject or a crown root, crown root. Okay? Cutting the median part of the bone through the activity cover. There is more in the bone. And any doubts in what we are doing? Myself removing the bone, any doubts that you are having? Because these errors, one or two questions. Myself removing that part of the crown. No doubts till now. Are you going to split the root, sir?
Yes, I am going to put the elevator and see, sir.
Okay.
If it is resisting, I am going to do it into.
Okay.
I am going to split the root.
So, sir, now activating this gutter, making this gutter a little more, putting a point of application. You can put a small point on the remaining root structure and try to push it into the space that is available. Yeah? So, you are going to try that. You can see it move. Yeah. Again, without too much force, you can try to flush it. Okay, elevating it into the space. Okay, now sir is elevating it into the removing it into the space created by removal of the crown. Okay, sir?
Yeah. The crown is divided into 3 pieces, sir. Okay?
Yeah.
And the entire root segment is removed. Okay? Looks more bulbous on the apical region.
Okay. So it is only removing the crown portion.
So once the tooth is removed, okay, the copious irrigation of saline is required to check for any fractured crown, because we have sectioned the crown into 3-4 pieces. Okay, so better to see any pieces of crown is there. Okay, any small remnants may cause delayed healing. Okay, yes.
Okay, after this, we have to move into the pipe. Yeah?
So once the tooth is removed, okay, the entire socket is inspected for any risk of hemorrhage, okay, any injury to the inferior alveolar canal, or any perforation on the lingual side, or any injury to the inferior alveolar nerve. Okay, so not such evidence is there inside. The entire socket is clean. Okay, so with few remnants of few irregular part of bone. So next procedure will be just filing it using a bone file. Okay, just to smoothen all the sharp bones. Okay, it is usually done in a unilateral direction. Okay, to remove all the sharp part of the crown. Sorry, bone. Sir?
Yes, sir. Okay.
Yeah. So then again the wound debridement is done with saline.
The sir has inspected the socket is clean, and any possibility can be removed now, but nothing is evident. So sir is making sure that hemostasis, that is, there is no bleeding. Hemostasis will be achieved. Two. After this, there is going to suture. It will be a quick suture. Okay, it is a non-absorbable suture. Always we have to try to give tension-free closure. Okay, only then the wound margin won't break down again, or any wound division won't happen. Okay, suturing also prevents the clot from being dislodged. Yeah, and prevent complications like light socket. Since sir used a modified one, more number of suture will be needed. You will have to suture anterior. So sir is suturing the distal here. Not what will be sir is suturing?
Sir, first I am suturing the mesial papilla of the 7, sir, for just for stability of the flap.
Okay. Yeah, so like I said, modified one. So it started from the mesial of the region, so it's suturing that segment. So you have been able to visualize an ideal tooth, okay, horizontal, typical impaction to do, and all the difficulty that you may encounter while doing a horizontal tooth. Okay, so if you plan and have an idea how you are going to go about it, if this will come out, what is that going to do? Anything that the loop is quite easy to do. Okay? Just needs a little practice and application. Always very important and patient is comfortable. Throughout the procedure, the patient is very comfortable. Okay? Though it took this much sometime more than we planned, the patient is comfortable. Yeah? That is what we have to learn first. Okay? To make the patient feel comfortable, which makes our procedure and our life much easier. So why do we need to suture? Usually why do we suture? Yeah? During pocket formation? Okay. Yes, any reason? Approximation of the edges. Yes. What kind of healing happens when you approximate edges together? Usually is what the primary healing. Yeah? Primary healing is much more convenient, less the fibrosis will be seen. Any questions? Clear? What sir has done? Any questions? From this side? Not even one question from this side. Anyone here? One. Sometimes you can close the anterior if you want. It is not compulsory because it is always good to have certain amount of space for drainage of the edematous fluid. Okay? Patient will always have edema after an infection because they have better flow. Okay? So that any doubts? So after removing the tooth, okay, you can ask the patient to have a ice pack, okay, ice fermentation, okay, for maybe a couple of hours, not beyond that, okay. So maybe for the first 6 to 8 hours, if the patient wants, okay, around 40 minutes an hour, intermittently you can apply ice fermentation that will reduce the edema that he has. Basically, the pain or the infection is due to, or the discomfort also is due to the edema that is going on. Okay? Lesser the edema, patient will be very, very comfortable. Yeah? The distance between the structure, yeah? It should be tight, yeah, so to prevent distal pocket formation. Okay? Are you all clear in the steps? Okay, good anesthesia, then exposure, sir has elevated the flap using a modified watch incision. Okay, after that, he has gutted the bone, buccal gutting and distal gutting was done. Since there was a lock in the tooth, so horizontally placed tooth, sir wanted to split the crown and the root separately. Okay, so he made an optic cut, basically from up to down. Yeah, and when we remove the tooth in front, 7 was still obstructing the path of exit. So remove the top part of the crown, that is we split the crown into further couple of pieces and remove the crown. After that there is an empty space. Okay, so we push the remaining two into the space. We will access into the space and remove it. Sometimes that may not work. You have to just slightly cut the roots. If it is a conical root or it's a fused root, you can push it into the space. Mostly it becomes easy. Sometimes if it is bifurcated, you may have to again cut the roots into half. Remove the upper root and the lower part, medial and distal root separately. Okay. After the sutures, a moist gauze or cotton, the patient is told to bite on it for an hour, around an hour, 40 minutes to an hour. Depending on the time period, you tell the patient to use adequate analgesic. Okay?
Hello sir, yeah?
Yes sir.
Sir, the suturing has been completed, okay? As you mentioned, the tight suture is being placed on the distal aspect of 7, okay? So once the suturing, because this is just to prevent the any periodontal pockets, okay, in future. So once the suturing is done, a small hemostat with gentle pressure is, a small gauze piece with gentle pressure is given, okay, to check for hemostasis.
Instructions that you will give a patient.
Yeah.
Who here done a normal inspection for okay?
The entire closure has been done, sir. This is the.
Yes, sir.
Okay. No brisk bleeding. Okay.
Yes, sir.
So the entire wound is closed.
Okay.
Okay. And the patient is comfortable.
Yes, sir.
Yes, sir. Yeah.
Yes, sir. Thank you, sir.
Thank you. Hello, sir. Yeah.
Yes, sir.
Sir, thank you, sir. Thank you very much. Okay. And I thank all the organizing team, Tagore Dental College, and I thank Dr. Simpson, sir, was giving me this opportunity to operate. Thank you. Yeah.
Thank you very much. Normal.
Is a reputed oral pathologist who is a professor in Sri Balaji Dental College and Hospital. She has multiplied national publications.
Introduction about the biopsy. So, as Dr. James sir was mentioning, before we start on with the biopsy, let's know about the patient history and the patient clinical features, so that once we have a general idea about all these things, then we can move on to the point of biopsy. So, starting with here, the patient is a 50-year-old male. The patient is a 50-year-old male, and he's been a partner of chewer for the past 8 to 10 years. He has stopped the habit 1 year before, but still there is reminiscent of the disease with he is having a limited mouth opening. So let's start with the examination of the patient. Mouth opening, still there are a lot of controversies about how to measure the mouth opening. The most standard way is to measure from 3.1 to 2.1 or again 4.1 to 1.1. So we could see that the mouth opening is approximately 26 to 27 mm here, so which puts us in a stage 2 of OSMF or stage 2 of oral submucous fibrosis. Apart from this, now we are moving on to if any lymph node examinations, because patients with limited mouth opening, pancaractua, they can have some lymph node swelling. So we move on to the lymphadenopathy swelling. Left side lymphadenopathy, I couldn't find any submental lymph nodes. Submental lymph nodes, couldn't find any. Moving on to the right side. So you flex the patient's neck and check for the lymph nodes. Not able to make out any lymph nodes on the right side either. So the next step can be to examination of the neck, but in this patient we found that there is no lymph node swelling present. So the next step is going to be intraoral examination. Intraoral examination, we are going on with mouth opening, limited mouth opening. Are you able to see?
Yes, Dr. Kannan, we are able to see that.
Okay. So what I could see is this tension developing and the patient is trying to open the mouth. Upon feeling his buccal mucosa, I could feel nice fibrous bridges spanning from the upper to the lower arch. I don't know if you are able to see this. Could you see the blanched mucosa here?
Yes, we can see the blanched mucosa. Do you palpate the horizontal and the vertical?
Yes, if you could see, my finger is running through the fibrous bridges here, and it is well palpable. So that is one characteristic feature of OSMF. Generally, patients have burning sensation and pain while doing that. Since he has been infiltrated already, he is not feeling much. And the bands are fibrous and it's bilateral, spanning from the buccal vestibule until the lower vestibule. And so once we finish with this, we have to examine the retromolar area bilaterally. Again, mouth opening is a difficulty. Are you able to see this area? The posterior area.
Yes.
The retromolar area. The instrument is pointing at that. The retromolar zone, that is also extremely blanched and fibrosed. That is an important reason why the patient is having limited mouth opening. James, are you able to see?
The retromolar area we are not able to see.
Okay. I'm reflecting the tongue.
Lip in the lip. No.
sir. Very good. So now is it visible?
No, doctor. I think it's going to be a little difficult visualizing that region.
Okay, fine. So we'll leave the retromolar region. The next area we have to examine is the circumoral bands. I could see, I think this is a little more appreciable. Can you see the fibrous bands here? My finger is moving across.
Yeah. Maybe since you're palpating, I think.
Yeah. Okay.
We can just appreciate the blanching there.
Yeah, there is a good blanching on the labial mucosa, and as well I could see some palpatory. It is very good feel that you can feel for the circumoral bands. In advanced cases, you can see there is a restriction in the movement of the tongue, but in this patient we don't find that. He is able to move the tongue well. So, thank you.
Yeah, the mobility of the tongue is not restricted.
So, this patient is having a bilateral fibrous bands spanning from the upper to the lower arch in the buccal vestibule. And that apart, if you focus on the left buccal mucosa, we could see some erythematous changes in this area. I don't know again this is appreciable or not. The limited mouth opening is restricting our vision here. This area we are able to see some erythematous patches, some changes. So what is alarming to us when we have a patient with OSMF is looking upon for an ulcer. because OSMF patients have the high chances of getting converted into oral squamous cell carcinoma. Chances are high, as high from 9 to 40%. So we have to look out for some whitish ulcers, which can be the starting point of oral squamous cell carcinomas. This patient doesn't have a whitish ulcer or ulcer of proliferative growth in the mouth, but he has a erythematous patch in relation to 2627 region, which could be secondary to the trauma from the cusp also. So now our focus area will be that, because we need to rule out any changes that's happening in the OSMF area. So let's start with the procedure now. The procedure will include, first is the infiltration of the area with the local anesthetic. When we speak about infiltration in a biopsy patient, we cannot infiltrate it in and around the area of the lesion. So we have to take a margin of at least 1 to 1.5 centimeter away from the area, and following that we need to infiltrate local anesthetic into this biopsy area. Please do not inject LA into the area of biopsy, because that is going to distort your histopathological changes or the findings the oral pathologist is going to look for.
Yeah, as an oral pathologist, I would also like to emphasize the point that the tissue of interest, don't directly inject your LA into the tissue of interest. Again, it is going to mask the cellular architecture, and finally we will not be able to arrive at a proper diagnosis. It will lead to vascularization of cells, it will lead to hemorrhage, extravasation, so all important details will be missing out. So please don't inject LA directly into the tissue of interest. Is one point I would like to emphasize.
Okay, the second procedure is going to be surgically scrubbing the area. This is important because the patient might have a superficial added infection, say something like a candidal infection or a bacterial infection. We don't want that to get to be included in our biopsy specimen. So thoroughly scrub the area and then go ahead with biopsy. So that is second. And the third step is going to be checking for pain if the patient is comfortable or not. Following that, we can go ahead with incisional biopsy, where we take a wedge of tissue involving the mucosa, submucosa until the muscle layer, involving a normal portion of normal mucosa also. So a biopsy specimen is going to contain three parts. One, it is going to contain the mucosa and submucosa of the normal mucosa, as well as the mucosa and submucosal part of the fibrous bridges here. All of these two have to be taken in toto and given to the pathologist. That's going to help them in differentiating between the diseased and fibrous tissue. So with this introduction, I think we can move on to the procedure. Bhagat sir, any questions there?
Yes, we can start with the procedure. What about the anesthesia? How much of LA plan and give for the patient?
We are planning to give a 2 ml local anesthesia, lignocaine with 1:80,000 adrenaline. The LA will be given as infiltration with a margin of 1 centimeter around the area of biopsy. As well, we are going to give him a long buccal nerve block and a posterior superior alveolar nerve block for the buccal mucosa and the posterior region.
Okay. So as we discussed, Dr. Tagore also says that, so he's going to give a nerve block, and then for local hemostasis, he will slowly infiltrate in and around the areas, but not the area of interest of biopsy. Because if you give LA into that area, the cell architecture might be altered, so that is what Dr. Tagore was also going to do.
I've also heard surgeons giving local anesthesia in a 4-point anesthetic technique. That is, you inject LA on the top, bottom, left, and right. They say it as a 4-point anesthesia technique. Do you follow that always?
Not always, madam. Say if it is a spherical lesion with a good margin everywhere and a good access, then maybe we can follow the 4-point technique. But if any time what could be preferred is a block which will serve away from the area of biopsy.
Yeah, you assess the malignant changes because OSMF has a pretty much higher malignant transformation rate when compared to leukoplakia. So you just assess the dysplastic changes when the tissue is being given to you, whether the patient is going in for a malignant change or not. So that is when biopsy becomes mandatory in all oral potentially malignant disorders. Now, we don't put them as lesion or condition now. World Health Organization in 2005 categorized everything together as oral potentially malignant disorders. So, if you come across any oral potentially malignant disorder, a biopsy becomes mandatory to assess the malignant status of that particular lesion.
Okay, to start with the biopsy here, we could see there is a small erythematous change happening in this area, and and that's the fibrous band. If you could, could you see me feeling the fibrous band in that area?
Yeah, we are able to see it.
Okay, so that's the area of interest. From here, we're going to keep a margin of say 5 to 7 mm into the normal mucosa. So the mucosa is going to be the wedge-shaped mucosa I'm going to remove, which is going to involve 5 to 7 mm within the band and 5 to 7 mm in the normal mucosa. So this area of the specimen is going to be removed. We can also plan for an elliptical shaped specimen, because sometimes the elliptical shape helps in closing the defect easier. But here in this case, it's better to have a wedge-shaped specimen. So the armamentarium we are going to need for this is going to be, so we are going to need, we are given LA already, so the LA is over. Then we are going to need a good retractor. So to start with, we need a BP blade and a handle, and we need what is called as an AdSense tissue forceps. Following this, we need to close the wound, so we will need a needle holder. Apart from this, we may need a artery forceps or a mosquito if at all we find some bleeding arteries. So to clamp them and to stop the bleeding, we may need a mosquito in this area. Is the armamentarium clear? So we need the LA is done. Then we need a BP blade and a number 15 BP blade handle and a number 15 BP blade. Then we need a tooth forceps to hold the specimen and get it out. Following this, if we have to close the wound, we need a needle holder. Meanwhile, during the biopsy, we may end up with some bleeding here and there because of the rich vascular supply to these lesions. So if we find a small artery or arteriole, we need a mosquito artery to clip it and hold it. So this is a very simple procedure with simple armamentarium and a few gauze pieces, of course, for the procedure to be to achieve some hemostasis in between.
Doctor, is the formalin bottle there?
Yeah, the formalin, that we never miss out these, we avoid these confusions.
I would appreciate a very wide mouth container there. And like most of the surgeons, they squeeze in LA bottles and give it. And that is what they find in their clinics, so they don't bother to collect some wide mouth sterile containers. So don't try squeezing your where you have red and white areas. Try to sample the lesion as much as possible. Try to obtain biopsy from a red area or white area if the lesion is large. If the lesion is small, focus on your red area with a substantial amount of
biopsy of the particular area, the anatomy of the particular area you need to keep in mind, because the opening of the parotid part also. So, do you see that, or do you have to avoid on that?
Yeah, but this patient must have it a little higher up in the vestibule because his mouth opening is restricted. I'm not able to have a look at the papilla here, and it's in close approximation to the buccal surface of the molars. So splitting the mucosa away from the molar is only very difficult over here. And what I could see is it is the midpoint between the two occlusal surface of the molars here. So this area is not the area where the parotid papilla can be, parotid duct can open up. The parotid papilla must be somewhere in this area. Are you able to appreciate? The place of interest must be somewhere here.
Yes.
Okay. So that should be the area where the parotid papilla should be exiting. It is not very much appreciable in this patient because of the marked fibrosis. So that's the fibrous area. So we are going to make a wedge-shaped lesion in this area. So the specimen will include mucosa, submucosa of normal mucosa, and as well as the mucosa, submucosa of the fibrous area. Always try to take the first incision through the lesion. Go to a good depth. Can you see the depth at which I am entering the lesion and making a vertical incision? Once that is done,
Again, why do you think the depth is of much importance here? What happens if you don't give an adequate depth in a case like OSML? Yeah, very good. You will appreciate the connective tissue changes here. So the problem is the hyalinization of the connective tissue which is causing the fibrosis there. And as well as you need to see the epithelial changes here. So without an adequate depth, you will not be able to come to a proper conclusion at all. And so is the case of a carcinoma. If you are not including your connective tissue in that, just looking at the epithelium alone will not suffice.
Similarly, I am making I made the superior cut, now I am trying to make the inferior cut here.
You can see how they are using the access tissue holding forces. Okay, so we make the incision, you have to hold on to the forces, retract the tissue away, and then slowly make the cut. My moves might be there from here around. Do not worry about that. You can finish the procedure and then control the bleeding. This patient almost the biopsy procedure slightly might be tough because of the limited mouth opening of the patient. So it's challenging for the surgeon. So he is manageable though.
Okay. Patient is feeling mild pain. Not sure what's going on. Very good. Just trying to connect all the edges together now so that I can get a equally depth specimen everywhere. So I have finished 3 incisions now. One is the posterior, the superior and the inferior incisions are done. Now I need to just make the anterior cut. So when you start coming to this point, try to keep the suction a little away because the specimen might get stuck. Then the whole point of biopsy is lost.
Yeah, I agree with that, Doc. Even suction tips directly, if you place it on the tissue, that can also induce artifacts, vaporization artifacts. So place the suction tip well away from the tissue of interest.
Trying to just achieve some hemostasis.
Shallower, broader biopsies are indicated in a particular type of lesion,
Okay.
vesiculobullous lesions.
Before
We can go in for a
explaining,
shallower, broader biopsies there.
madam, can I just see the specimen once before I remove it? So the specimen is almost out. Can you all see the specimen getting expanded from the base? Can you see that?
Yeah, we can see that.
So that's the specimen which contains mucosa, normal mucosa, and the fibrous tissue until the muscle layer. So now the last cut is going to be the base cut. So I am trying to pull it a little from the base. I am trying to make the cut at the base of the lesion. Onnilla sir, vaayatharanga mudinjiruchu. Mudinchina. So that's a specimen.
So you just rinse it in saline and immediately you transfer it to.
I just want to show the specimen once before we transfer it to the formalin. Right, come here. So if you see the length, the depth of the specimen is almost similar every way. So we have the mucosa and the fibrous part, and as well as the depth of the mucosa remains the same almost every way. Which is very important because you cannot give varying depths to the oral pathologist because they may not be able to assess the characteristics everywhere thoroughly then.
So it's being transferred onto 10% formalin. That is the normal fixative that we use in clinics. This 10% neutral buffered formalin. We prepare that from 40% formaldehyde, 1 part to 9 parts of distilled water. So that's a common fixative we use. We have other fixatives too. If you go in for a different microscopy, you have to use other fixators. For electron microscope, you have to use glutaraldehyde. So fixatives vary, but common fixative used in clinics will be formalin. For a vesiculobullous lesion like a pemphigus or a pemphigoid, I think you can take 2 tissues. One for a routine H&E sectioning and the other one for immunofluorescence studies.
Okay, now we have seen that the biopsy is performed. We see a good defect there, which is pretty much the same size is visible. Is the depth of the lesion visible here?
Depth of lesion is visible.
Okay, so
Yes,
that's the muscle layer. So mucosa and submucosa layer together. And now we need to make a suture to just approximate the defect. And the suture should always be taken in the normal mucosa. Try not to pass the needle through the infected tissue or through the cancerous lesion, because by doing that we are going to seed the lesion deep into the deeper planes. So always you know that you have taken a margin from the normal mucosa and involve only the normal mucosa in this area. Take the bite even wider away from the lesion, no problem. Here it is not about the rules of suturing, it's about closing the area without sealing the lesion into deeper planes. Since we have not given the patient a block and it's most part infiltration, let's try to close the wound faster.
So as we suturing, let me ask one more question. That's how much of formalin are you going to take for this tissue? Is there any ratio? So for one part of tissue, your fixator should be 50 to 20 times more. Right, so 1 is to 15 or 20. So that should be the volume of fixator for adequate fixation. Huge specimens, sometimes when the lower part tends to rest on the container, you can actually suspend the specimen in the container. Because the lower part is again not going to be fixed if it's going to touch the container. So actually you can suspend the specimen in a container if it's going to be a huge sample.
Okay.
Yeah, again the size of the specimen again matters, because once you put it into a fixator, the tissue is going to shrink. So if you are going to give a very little of tissue, it will be of no use to the pathologist. So give an adequate specimen size, because after fixator your tissue is going to shrink and the tissue size should adequately compensate for the shrinkage.
So we have passed a single suture on the normal side of the mucosa that is getting the biopsy spike little approximated. Outer side is totally closed. I cannot close it totally because the rest of the area is a lesion. I don't want to pass the needle through the lesion area. So that marks the end of the biopsy procedure here. Bagacha, any questions, any doubts?
So if you place a suture, it
Right, up. To avoid any bleeding in that area. Okay, sure. Why not?
That's a good question you asked. So what happens once you take out the tissue? So if you take out the tissue, what happens? It starts to undergo autolysis and putrefaction. So that is the main thing.
Right, so now as you see that this gentleman is missing the lower left first molar. So it's a 3/6. The radiograph was there somewhere, which was shared to me earlier. Now what we are planning for him is, now close your mouth sir, cutting you sir. If you can see in the mirror, focus in the kutti mirror, there is an adequate amount of space there for us to place a tooth. The supraeruption is minimal. Dr. JK?
Intro that your video is not focused, sir.
Okay, right.
Even the mouth mirror is fogged.
Is fogged. Okay. ஒரு கொஞ்சம் தண்ணி கொடுங்க. ஒரு cheek. Sorry. Any better now? Close.
Yes, perfect.
Yeah. So it does have. This is not like what you say. We have lot of ideal situations. In fact, actually, this gentleman has got a fair amount of resorption, but we have enough bone in which we can go ahead with the implant. Now we are talking about a buccolingual resorption. Now height wise, I think he has got enough cutting here. Is the video capturing that we have space between that, like the interarch space wise, we do have space. This gentleman has just been numbed up. He went through an antiseptic mouthwash just to make sure that his oral preparation is slightly better. Yeah. The system what we are going to use. Okay. Now when we talk about implant systems, I'm sure like Dr. Yasir and Dr. JK there can focus. We have a lot of different systems in the market. The system what we are going to do today is a MIS system. Now but at the end of the day, most of the implant systems are similar in the sense that whenever you are looking at a system, you look at the layout. It starts off with what we call as a spade drill, which is what we have actually located in the either focus point. Right? Now this is a very sharp drill, as you see. This gives you the initial purchase. After that, we go through what we call as a sequential drilling. We have to go prolongly, we have to increase the size of your osteotomy site step by step. Most of the time, the drills what we use are high speed. You guys are all used to the conservative department, where the aerators what we use have got a speed of about 250,000, which is 2.5 lakhs. Can we just focus it over here, please? This one. Now, this is a physio dispenser. When we talk about a physio dispenser, this handpiece itself is special in that it reduces the speed. This reduces the speed on 20 times. It has got gears. So we have a speed of only about 1000 RPM. We are talking about 1000 here is 1000 RPM. The ideal speed for an implant placement has to be anything between 800 to 1000. You can set up the torque. We are talking about a low speed, high torque motors whenever we are talking about physio dispensers. They are like what you say, a sophisticated micro motor. That's how they are. Yasirji and JKG,
yes sir, clear, loud and clear.
Kindly get some questions from the audience, and so that like we can be as interactive as it can be.
Yes. Any questions to be asked at this point?
Maybe anything regarding the kit if they want to.
Yeah, anything about the kit machines? Have any idea about any systems? So they don't have any idea about any systems. Can you explain the kit in details?
Yeah, why not? Yeah, just. So, as I said, the first drill what we are going to use is a lancet, or many a times you come up with a pilot drill. Some systems come with lancet, which is a very sharp drill. A pilot is the one which goes in the front. I mean, if you have seen VIP convoys, those are the first thinnest drills. Then, as I told you, we are talking about multiple drills. I will start running them and show you. Now, you can see most of these drills will have markings in them. Can you focus it a little bit closer, sir? Most of the drills will have markings in them, because the implants, one of the main thing about implant goes into the planning. What size of implant am I going to place, both in terms of the depth of the implant or the height of the implants as well as the width of the implants. We'll silence it. So we talk about the various depths. We have implants which starts at 8 millimeters, 10 millimeters, 11.5, 13, 16. These are most of the so-called custom stock implants which are available in most of the things. So we go for sequential drilling, which means like if you are going to go for an implant as wide as 5 millimeter, you don't start with the 4.2 drill. You start again with the pilot drill, then go sequentially as 2, 2.3, 2.7, 3.2, 3.7 and come to 4.2. Because the most important thing about implant osteotomy site preparation is the temperature of the bone, the core temperature of the bone. We have to make sure that it does not exceed 47 degrees for any given minute, because after that the type of bone regeneration what you can get from the bone is minimal or non-existent. So your implant is not going to osseointegrate, because it's a screw at the end of the day, but this screw will not come out after it integrates with bone. That's one of the main things which we have to probably say. I think we are ready for the...
Yes, sir.
I think we'll be ready shortly. So if you give us a few minutes, I'll start with the flap. But in the meanwhile, please go ahead and explain to them, so that if there are any questions, we will probably start doing them. Thanks, Dr. Yasir.
See, nowadays implant is a one which everyone like to practice. So you need to know implant. Most of them are from UG or postgraduates. Any postgraduates? Okay. See, like most of the clinics, like you go ahead, it's like nowadays implant practice. It's like becoming a 5-6 system, and autoclave and keep everything ready. The patient comes, next move will be what system you want, what budget you want. You should be very confident doing implantology at this scenario because the future is going to be implantology, right? So these are the things you have to need to know. Implant is not just we can see a single implant and you just go ahead and do. It is an idea. Sir is giving an idea as to how to go about a single implant. Okay, there's a lot of criteria you have to go about, have to learn. And speaking that, if your patient is coming for you for an implant, there is a lot of systems in the market. Starting, even I know some people around in Kerala, they are doing for even 10 or 15,000 rupees for an implant. So you need to know a lot of systems. There is a sequential learning of implantology. You have a lot of courses, and you should attend it, and you should get to know about the implants. Any doubt over here?
Don't think that a closed surgical procedure is any easier than that of an open surgical procedure. All of you are taught about how to raise a flap, the basic oral surgery principles have been taught, and you know how to do suturing. That's one of the biggest advantage in dentistry. All of you guys are surgeons. You are all dental surgeons. So we can do suturing. You have made a flap. All what you are going to do is here, as I see, like here, this is a number 15 blade. If you can just focus this. This is a number 15 blade. This is the most common blade which is used in oral and maxillofacial surgery, right? A number 3 handle on a 15 blade, and my armamentarium here are fairly simple. We are only talking about a periosteal elevator. We have Harvard's periosteal elevator. We have a couple of forceps, a tissue forceps. One has got a tooth at the end. You can see that it's a tooth absence. We have non-tooth. Suture needle, a needle holder, and a receipt. That's our armamentarium, plain and simple. Now, this is a fantastic one. I'm sure guys in the intern would have seen it. Finally, you might not have seen it. These are what we call as a Mckeson's mouth prop. All what this does is, I'm going to bring it back to the patient. Here, this one. Whenever we talk about implants, now you can see that the patient can rest his mouth, but the mouth opening is still maintained. That's the most important thing. Another Austin, so that we can retract it better. Okay, so now what we are going to do is, I'm going to. Yeah, fantastic. For this patient, I am actually going to do a standard crustal incision, which means like I am not going to make a relief.
So, a doubt here.
Yeah.
You're going to make just crustal incision or an off crustal? Nowadays, people are moving about off crustal.
Yeah.
We can throw some light on that?
Yeah, we can. See, the thing is, initially when we are when we are talking about the ideal implant placement, right? Now, there are a lot of concepts here. We are talking about, when we talk about like maintaining, particularly when you are coming to the aesthetic zone, people talk about maintaining the marginal gingiva. Now, these are things which are much more easier to perform for anybody who is beginning. And 1 second, doctor. And what I have done in this particular one is only a crustal, so that I can raise both the buccal and lingual sides as a textbook, as if it is opening as a textbook. I don't need to make big relieving incisions at all. We can just open up the flap. Dr. Yasser, in the meanwhile, you could go ahead and explain to them about the various.
Yes. So, sir is making a standard incision called crustal incision. You just put connecting line between the center of the crust and we can read like a boom. Okay. But the problem is, once you go for extraction, the healed socket, what happens? The attached gingiva is something called attached gingiva, the keratinized gingiva. It is very minimal. The muscle tends to come through the filmy crust. So nowadays, what we are doing is something called off crustal. We want to maximize the keratinized mucosa around the implants. So we reposition the keratinized mucosa from the lingual aspect. So we do a off crustal incision and reflect the mucosa. So that when suturing all the keratinized mucosa, I need to say the attached gingiva will be on the buccal side. The implant long-term survivability depends on the exact soft tissue management. Over to you, sir.
Yeah. So, one of the things about when we talk about 3-6 region, though it comes as a posterior tooth, as a beginner, I guess this type of, like what you say, either a 3-6 or a 4-6 or a 2-4, that is the first maxillary premolar region. Those are areas which I would probably suggest as the first implants for anybody, because when we talk about aesthetic zone, it becomes all the more important that we maintain so now, not sure whether the camera is focusing. Now we have raised the buccal flap, and now I have raised the lingual flap as well. Can we have a little bit of saline in there, please? Yes, sir. Yes, sir. Can I?
Yeah.
So that is the residual bone, guys. Now we have just opened up the flap as a textbook from both buccal as well as the lingual side.
Yes.
Right? And now you see that at this level, that is at the crustal level, it's still a slightly thinner bone. But we can afford in this particular patient, I will show you the calculation. So I'm going to.
Sir, can I have pre-operative OPGs, X-rays?
We will show it from the mobile. Okay, I think the film nowadays we have gone digital. That's a problem. We don't have films in most of the things. Can you focus this? Can you see, doctor?
Yes. As you all see from this IOP image, there is a lot of bone loss, crustal bone loss.
Correct.
And we can't really see the position of the nerve.
But what is available is easily about 15 millimeters of bone is easily available.
Easily available, yes.
Available from the crest. We are at this particular juncture, I think our people have already done a marking, and we are actually planning to place a 3.75. So you can see, can you focus this one, please?
Yes.
Yeah, great, doctor. I'll take that. Abhi over.
So you're planning to place 3.75?
Yeah, at 3.75, length is 11.5.
Yes.
Now, for the simple reason, though I have a crystal thing of about 14 millimeter, the only problem is because of the way the resorption has happened, we might sometimes be ending up taking out the surface. We might have to trim out the crest, which if it is knife edge, to make it a small plateau, and then start your implant procedure. So this is more of a preparatory one. 11.5 is fantastic. Now, our people have made a small surgical stent. Can you just focus on this, please? Now this is, if you see, this is actually nothing apart from, on the undersurface, we have, that sits on the premolar, that sits on the second molar, and they have just placed one acrylic tooth. This one if you can actually place it in the patient's mouth, it fits so very well. Now, at the end of the day, we have to remember implants is a prosthetically driven specialty. Implants are done by 3 specialties. They are done by the surgeons, they are done by the prosthodontists, they are done by the periodontists. But at the end of the day, it is a prosthetic driven specialty. What do I mean by a prosthetic driven specialty? Now, JK sir can actually pitch on it. At the end of the day, the patients have come to us for an artificial tooth. So, we are going to provide the foundation for them to get a tooth. So, in simple ways, you can have a fixed replacement when somebody is missing a tooth by either sharing the load on the neighboring teeth, or you put the load on the underlying bone. So, all what we are doing here is to put a foundation on the underlying bone. So, when we are doing that, the bone should be able to take that position, but more importantly, it has to go in a position that the tooth can be restored. So you can't put in a foundation where it cannot be restored. Then you call that as a failure. Even if your implant is so strong, you will call that as a failure if your implant cannot replace a tooth. So that's the reason why we keep on saying that it is a prosthetic driven specialty. So can you guys see the position of that splint?
Yes, sir.
Yeah, so it's a very simple one, and anybody, all of you have done so much of prosthetic work. So this is, we have very advanced splints nowadays. We have a lot of digital splints. The digital splints, particularly when you are going for Dr. Yasser and Dr. JK can throw some light on it. When people are missing multiple teeth, we do a lot of planning. As I told you, implant is more about planning. So we should know where to position our implants. So here you can see that this particular splint is actually sitting there on the tooth. On either side there is a tooth, and so all what we are going to do is we are going to mark the site of the implant. That's it. So this drill, when I start pressing it, at the moment I am just going to take it for a minute for you to just see it. I am not going to drill it, I am just going to show them. So when we, these are cooled bursts, which means like they have a irrigation pump there, and that irrigation pump in these strings are built in. So when I press my irrigation is on. Yeah, irrigation is on. I think this is
Sir, it needs to work.
just 1 minute. It's okay.
If you are final year, no?
No, this is not
Final
correct.
year students?
This is not correct.
So maybe
One
if you are
minute.
going to
One
begin
minute.
with implant modality. Sir,
Dr. Yasser, I'm just
yes, sir.
showing them that,
Yeah.
that this we are talking about a cooled bar. So it comes and hits this water there, comes and hits against the bud tip where it is actually drilling the bone. So that is one of the reasons why we are talking about that. These are cooled to select. Ideally we have to go in for what we call the legal active, which has got much lesser. See, we are talking about physiological irrigating solutions.
So you have an articulated diagnostic chart, so it has got a lot of benefits. One thing that shows that you can just evaluate the amount of space available, you can see the discrepancy, the occlusal plane, the opposite to the superior, or if there is any blending cut. Okay, all these things you will get to know if you have an articulated diagnostic chart, and also it will help you in preparing a surgical stent. Yes? You can also use the diagnostic chart for preparing a radiographic stent. You can put a marker or a radiographic marker if you want to take a location of the ocular site, or you can convert that into surgical and whatever.
Dr. Yasser, we are just marking the site of the
Yes,
bone.
sir.
I might have to use a drill extended here because we are talking about a fully bounded saddle here. Now I have marked my site where I want it. Now the most important thing in the first bit of this implant placement is your three-dimensional positioning of your drill. Your first drill means a lot because we have to be parallel to all three planes we are talking about. So my drill has to not go towards the premolar, not towards the molar. So it has to be in a neutral zone. I actually have a marking, I am afraid. So here you can see that my drill, I am actually trying to place it along the bone. Over please. Move the line. Am I blocking the way, or you guys are able to see it? Is the
Actually, the site is not visible, sir.
okay, but the thing
Only we can see the drills.
Okay.
But we can't see the site of preparation of your drill.
Okay. I'll see whether I can do it a little bit. Just 1 minute. Now I have actually made another attachment.
Yes.
This attachment, now all I need to do is slot it in. This one will just slot inside. So my drill is now extended. The advantage is I can now reach even the previously unreachable areas, particularly when we talk about bounded areas.
Yes.
This is what we need to do. Am I any better?
Yes. But still we can't see the site.
Site is because unfortunately,
Yes.
just give me a few seconds.
Yes.
We will definitely get a better visibility.
Yes.
Surround, please.
So sir is starting with the last drill. That is the initial drill for most of the implant. The beauty of this drill is it is sharp. So the other drills which are not as sharp in the tip. So this has a sharp tip. So you can enter the cortex, just puncture the cortex. It's just purpose is just to puncture the cortex, and once you get into the cancellous bone, you can take out and you can go for the regular pilot drills, and sequentially you can expand the osteotomy.
So we have gone through the initial drill. I'm going to use the next drill. Usually all these drills will be marked, and here I'm not sure whether it can focus that much. Here it will probably say something like a 2.0 drill. There will be a marking in these drills. All these drills. Now when I make it run, now when this drill is running, you can see, can you focus the drill please? Can you see that you can see the markings when it is running very clearly. The first marking will be a 8, second marking will be a 10, third marking usually is 11.5, 13 and 16, something like that will come. Now the end of the drill will have an apex which will go to 1 to 1.5 millimeter, which will not engage the implant. Implant will be there in the cylindrical side. Right? Can you guys see it? When you are running the markings, can it see? Dr. Yasser?
Yes, we can see it.
Yeah.
At this point, I want to more say that there is a few companies like Noble who has a drill which is length determined. In
Correct.
this,
Correct.
you don't have a stopper, so you should see the marking always to stop where you want. You're going to put 7.5 mm length of implant, you have to stop exactly over there or little more. But some companies like Noble or a lot of companies, there is a length determined drill. That means there is a stop. 7.5 mm means exactly there is 7.5 mm drill. You can stop, and there is a stopper, drill won't go after that. Right? At this point, I have one doubt, sir.
Yes, please.
3.75 in molar region.
It's not ideal.
Yes.
We will actually like to go for 4.2 and above at least.
Yes, the minimum 4.
Yes.
So what do you like to say about this one?
This particular, in fact, actually that is what I requested for. But the bottom line is because of the very narrow crystal bone. See, normally that the requirement part of it, what it says is you need to have a minimum of 1.5 millimeter of bone on all sides of the implant. So if your crystal width of 4 has to be there, you need to have a crystal width of ideally 7 and above for you to get a 4 millimeter implant with having bone all around. If you have a bone of less than 0.5, we are definitely not looking at an ideal scenario, because then the bone will start dehiscing and then there will be a recession and eventually the bone things can get lost. Now we have now placed, I'll get back to that particular point what you have mentioned in a minute, Dr. Yasser.
Yes, sir.
What we will also do right now is we will try to place a paralleling pin and then see, of course we are only going to place one implant here, but it will give us a direction of where our implant is going. Now if you can see, this is where my socket is. Can you see that instrument?
Yes.
This is what we call as a paralleling pin. Particularly when you are doing multiple implants, these implants have to be parallel to each other. Now if you see it, the inclination of it, it's neither too lingual nor too buccal. That is, I am talking about a mediolateral direction. But if you talk about the anteroposterior direction, it's neither inclining too much towards the premolar nor towards it. And then right now I am going to take off this mouth prop. I am going to ask my gentleman to gently close his mouth. Lesa vaai mudunga, lesa vaai mudunga. Indha pakkam thirunga. Now vaai mudunga. You can see that the potential. Can we see it at all?
Yes, sir.
The potential place where this implant will emerge, you can see that it is exactly in occlusion with the opposing tooth. Now, this is exactly what we said. We need to make sure that our implant is going to be useful for the patient. There's no point in putting a titanium structure which will eventually integrate, but you can't give a tooth on it, right? So that is why we were talking about a prosthetically driven type of one. Yeah? Can you open it? Why sir? Focus. Any questions on the implant directions so far, Dr.
Yeah. This looks fine, sir. Absolutely fine.
I am actually waiting for comments from Dr. JK.
This meeting is a prosthetic part to the more of the surgical intervention.
I know this is a live surgical workshop, so I think they have cut that out. But what is your opinion on that, Dr. JK? Like, because this needs to be, the prosthodontists need to be aware of how it is going on.
That's what I was just briefing them just moments back. As a beginner, they should have an application class.
Yes, so, that's right.
So just for a beginner, it is better to have a class at hand where they can just do a mock teeth setup.
Yes.
And they'll be able to know the exact occlusal contacts.
Yes.
And the same can be transferred as a surgical guide.
Yes.
So no. I think that is how they would have done this guide also.
I think, yes, we do. In fact, actually, they can show the models at the end of it. We will probably show, and then another end of model. Sister, at the end of model. In fact, we should never forget the basics. We are here because of our entire dental knowledge. Whatever specialty we are choosing, at the end of it, we need to be very clear. And if you can actually put it in the occlusion, and then actually you know exactly how much space is there. More importantly, whether can my patient open the mouth so that I can place an implant, and is there enough space mesiodistally, buccolingually, superior-inferiorly, all the stuff we have to probably look at. Now, I placed this paralleling pin. This part went inside the osteotomy socket. Now you can see that there is a hole. Most of you guys who would have done root canal treatments, you will find that all your files and reamers also will have a hole. Theoretically, they all have to be tied to a dental floss, because these are things which need to be looked at, because these are small pieces which can slip. And should it slip, if a patient swallows, no harm done, but if the patient aspirates it, it can become an emergency. So particularly when we have a patient who is numb, we have to be that extra careful. Yeah?
Sir,
Yes, sir.
initially, before beginning the surgery, what anesthesia was given?
Sir, again, that is a different type of opinions are there. In this particular patient, I went ahead and then gave an inferior alveolar nerve block. But there are people who suggest that you should only give an infiltration and not give a nerve block, because that will be a good indicator whether we are going closer to the nerve. But honestly, nowadays, if you feel, 1 minute, I'm going to give a rest to my patient. Now, if we have now come to an age where certain type of investigations are freely available. Now, at the end of it, if you are doing an X-ray only based on IOPA or OPG, if everything was normal, nobody asked a question. But if it was a touch and go with the relationship of the nerve, instead of giving infiltration and testing whether I am touching the nerve or not, I will definitely advise to go a CBCT, a cone beam CT of that area, because that will give a much more clearer indication of what is the distance, and that is the best way to forward to do that. So if in doubt, I think you have to err on the side of caution, which means go ahead, have a CBCT, have a planned guide which will give you an exact positioning of the nerve, and then do your surgery. Don't actually risk saying, okay, I can just keep it short, I did not get a bleeding, and those type of things. Let us not do that. It's ideal to go in for the next set of investigation, because that will save a lot of headache for everybody, both for the patient, but I have to say for all operators.
Thank you.
Okay, now I'm going to go to the next, right? My first drill will be a 2.4 drill, which I just took it out. Yeah. This is a lancet drill. See, you can see the drills where I'm keeping it here. This has a straightest profile. The lancet drill, which I used first to pierce, is of course, it's like a knife, right? It just goes in and out. That does not prepare the osteotomy site, but it gives the direction. My second drill is a straight drill, but my third drill onwards, this is a tapered drill. When this one says 2.1, 3.1, is it 2.1 or it is 3.1? It tapers from 2.1 to 3.1. So on the tip it has a 2.1 dia, and on the crest it has a 3.1 dia. So you always do one step, you can under drill it, particularly depending upon the type of bone you are looking at. So I am going to use my first taper drill right now. So I have put that drill on. So the similar protocol. So you can see that you have the things and the markings again comes through. So we are going to go through the third marking, which is our 11.5, which is what we have planned for this patient.
How do you do RCT? Most of you we wait in RCTs, anterior procedures. Most of you know to do. So what they say, you have to.
Dr. Yasser?
Yes, sir.
Through this mirror, by any chance, can they see? Of course, because this is hidden, even for our own vision.
Yes, sir. Yes, sir.
Can they see the osteotomy side?
Yes, you can see the osteotomy side.
Yeah. So
yes.
As you can see, now it is positioned in between the premolar and the molar. And if you are talking about between buccal and lingual, we have shared it equally in between that. So, and the direction of the drill also, once the first drill goes in, the second and the third drills literally follows the first drill. It is extremely difficult to change the direction after you have created a pathway. Do you agree, Dr. JK?
So you have to make absolutely right. And another thing I would like to tell you is placement of the implant. Now in this case, sir is placing in 3-6 region. Okay? So even though he has placed the equidistance between premolar and molar, are the basic guidelines. Okay. So from natural sources, so suppose you have 3 molar. Okay. So they have planned 3.75 into 11.5. 3.75 is the diameter and 11.5 is the length of the implant. The basic guideline will tell you that suppose to place the implant, the distance, minimum distance between the natural tooth and the implant will be around 1.5 to 2 mm. Okay, the distance, not closer than that. And the implant, suppose we are going to place multiple implants, no, adjacent implant, then the space is little more. So it will be around 2 to 3 mm. So if you follow these guidelines, you will be able to place the implant in the predictable position. Okay, as I was just discussing in the study about the amount of space that is required. So as I told you that you need to have a minimum of 8 to 12 mm. Okay, 8 to 10 or 8 to 12 is fine. But what if the space is very less? The implant space is very less. When you have reduced implant space,
I don't want to lose the predictability.
when you have a reduced implant space,
Dr. JK,
yes sir.
I have used the 2.1, 3.1 drill.
Okay.
The next drill on this sequence, unfortunately, is a 2.8 and 3.65.
Okay,
Now, my implant itself is only 3.75. So sometimes it's ideal. In a maxilla, you have to undrill. But in mandible, if it is a dense bone, we do talk about qualities of bone. In mandible, in an anterior mandible, you are likely to encounter very, very dense bone. We call that as a D1 bone. In posterior mandible, most of the time you end up with what we call as a D2 or a D3 bone, which means we have a fairly good cortex with a compact cancellous bones. So here I think I am looking at about D3-ish bone rather than a D2-ish bone. So I am going to start with the under-drilled osteotomy side. I'll see whether I can drive in my implant. If I feel that I can't drive in my implant, I'm going to reverse it back and then go for the next drill, because the next drill is going to be exactly the same fit for the implant size. Am I clear or should I explain any more?
everybody is clear on this? Sequence of
Okay, I think I will take the questions, but see, this is a ratchet. I am going to show the next bit of it. This is a ratchet. What do I mean by a ratchet? I am sure you would have heard about spanners and screwdrivers. Now, this is what we call as an implant driver. This will fit inside the implant head, and this is an implant driver. This ratchet is like a spanner. Now, if you look at it, here it says, can you focus this? This says out. In this one, if I have to remove an implant, in other simple words, what I told them is, I will try placing my implants, but I cannot torque it beyond 45 or 50 newtons. If I give all the force what I have and drive an implant, I will lose the thread on the inner side. My implant might become useless. So don't use your might, use your brain, right? So here we are talking about in. So all what I have to do it is, I have to slot this in. When I slot it, now I am going to hold this driver together, and when I do it, if you can see that it is actually turning. Now I will show you here. If you focus this one, sir. Now when I am turning it, in other words, when I am tightening it, it is turning. But when I am reversing it, that is not turning. That's the ratchet, okay? It's a one-way thing. Now, when I want to loosen it up, what I have to do it is, I have to take the same thing out. I put this upside down. Now, when I am loosening it up, it will turn. But when I do it tightening, it doesn't turn. Are you able to see it through the video by any chance?
Yes, sir. Yes.
Excellent. So now what we are going to do is, we are going to use the inserting tool. So here we have both sizes depending upon which area we have to go. So this is a longer one. We also have a slightly shorter implant driver. So you can see that implant driver comes in the regular sizes, 2 sizes. I am going to go for the longer one for the time being. So now my doctor is going to give me the implant transfer either way. Now implants show the cover also. So sir has opened the cover and just transfer it.
The last osteotomy is finished, sir?
This is last but one. I am actually going to try it because I feel the bone is a bit more softer.
Softer, okay.
Yeah, so I am going to try placing this. If I feel that it is too tight, I will reverse it. So this is the inner container. Thank you. Now you can see, now this is a sterile container. It says 3.75, that's a dia, and 11.5, that's the length. So when I open the outer one, now you can see that I can see the implant's inner surface. Can you see that?
Yes, sir.
Right. So now this implant driver can be fitted onto it. So you don't touch the implant and you just take it out, you see the implant.
Yes.
Yes, everybody?
Yes.
Yeah. So now what we are going to do is, at this particular time, you try not to touch any other metal surface. Can we readjust the light? Try not to touch any other metal surface. So I am just placing the implant there.
Yes.
And then the important thing about, so I am tightening and the implant is freely moving in.
Yes.
So as you see, I am loosening it up, nothing happens. I am tightening, it goes inside.
Yes.
Loosening, tightening, tightening, tightening. As you are, sir, can we see the implant at all, where it is going?
Yes, yes.
Yeah?
Yes.
And I am actually using very little torque. So in fact, actually my decision of keeping it one step down, I think in this stage, I think it is better. If I had gone for the next drill, my implant may not have the type of stability which I would really like. I am going to take it. I don't think I have fully driven it in, but I would like to show where we are. I think we are almost there. You can actually see. I'll try to get the camera to show it. Can I have some sunlight, please? Yeah, there it is. Now my implant is proud by about 1.5 millimeter. I'll take one more mirror. Can I see my mirror at all?
Not so.
Okay, just give me a minute. I think I'll swap the mirror. This is very dry. Can I give this to you, doctor? I'll take the other mirror.
Yes, sir.
Yeah?
Yes.
I have to still drive about 1.5 to 2 millimeter of my implant has to go inside to make it flush with the crestal bone.
Yes.
Now, Yasaji, I mean this
Yes.
one, in an ideal world, I would have preferred to go to 4.2, but to be perfectly honest, that's the amount of bone what I have.
Yes.
Here,
Yes.
I am placing an implant now 3.75, 11.5 for a single tooth. I think it's still okay.
It should be okay.
It's not ideal, but I mean I would definitely not place a 3 or a 2.75. I wouldn't go for a very narrow one. This still comes as a, and they can definitely think of platform switch. I think Dr. JK can just explain. I think there might be a few postgraduates there. For their benefit, I think we will just tell them what a platform switch is. Almost one minute. Yeah.
You know this standard implant, what sir is trying to inside the patient's bone, it does not come with the implant fixture and the abutment. Okay, implant and the abutment both come with the standard. But in the platform, it is the platform on the implant head is going to receive the abutment. Both are the same diameter. Okay.
Just for the thing, I have now driven that 1.5 millimeter again. In fact, on the lingual side, if you can see that it has become really flush. On the buccal side, maybe just a half a thread is missing, but honestly, if I go any deeper than that, bone will overgrow my implant when I am placing my abutment. So I think I am going to stop here. By any chance, is the focus clear? Can you see the implant?
Yeah, fine, sir.
Yeah. Now, this is like, we talk about a lot of different type of implant placements. We talk about immediate placement, which means we take out the teeth and place an implant. Would I advise that type of implant placement for a beginner? I don't think so. You shouldn't attempt those type of ones for the first probably 50 to 100 cases of implants. Immediate implant is a different kettle of fish. Then another thing they talk about is an immediate loading. Immediate loading again is which means that you give a tooth immediately. Now I tell my patients, like Dr. Yasser said, I do a lot of implants, but I tell my patients, most of my patients, I am sorry, I belong to the old age group. For me, if you come for as an implant patient, you have to wait as if you are waiting for a child, which means you wait for a period of about 9 months from today to the time I give you a tooth. It because sometimes I have to prepare the site, I have to put bone graft, then I place my implant, then I give my provisional, and then I go for my permanent. So anything you have to wait. If you want good things, you have to wait, I am afraid. This is what I said. Dr. Yasser and Dr. JK, your take please.
Yes, sir. The placement is perfect.
Perfect.
And
now this one, sir, now there are different type of drivers. See, this is what we call as a cover screw. If you look at it, it's a very flat screw. It's just going to protect the inner aspect of the implant. And this driver again is a hex driver. These are all friction fits. In other words, if you place it there, it will stay there. It will not fall off, right? And they are all coming with a finger grip. All what you have to do is you are going to place your cover screw straight into the implant site, the same angulation that it went, and just a finger tightening for this more than sufficient, because when we are talking about a cover screw is never tightened with your ratchet. Just a finger tightening, that's more than sufficient. Now, if I show you the picture again, you will see that the hole which was there is now covered. Am I?
yes, sir. Yes.
I will show you the lingual margins also. Yeah?
Yes. Yes.
So now, in fact, actually this has got a fantastic primary stability. Now, when we say primary stability, that's one of your keys of success. When you place your implant, if your implant is shaky inside the socket, the chances of that implant succeeding is going to be extremely low. So when you are placing the implant, you are looking at the insertion torque of at least 30 newtons. So when you are doing it, there are a lot of insertion torque materials. I mean, if you go through the literature, it will show like how much force you are putting in when you are placing the implant. If it just goes by a very simple finger pressure and it's still shaky, then the implant has very poor primary stability. These type of implants have got a very good primary stability. Leave it for 3 months for a mandible and about between 4 and 6 months for a maxilla. This becomes part of the bone. In other words, it undergoes what we call as a osseointegration. In the second stage, Dr. JK will explain to you like what we do. We take out the cover screw and then we made another attachment and then we can go in for a crown. There are a lot of different ways of doing it, but that's pretty much it. Any questions from the audience side, Dr. JK and Dr. Yasser?
It's good, sir. Actually, it's explained clearly. And we talked about this platform switching. Stop in between.
So can I just go ahead and do the closure when Dr. JK is doing that?
Yes, sir. Yes, sir.
Closure, I am in this case I am just going to do a simple interrupted sutures. We are going to use a silk suture. You can use interrupted, and we can just get rid of it in about a week to 10 days time. Patient will be placed on a standard set of antibiotics. It's not like, if you actually ask me whether it is mandatory, because we have perforated the bone, I would probably still use it. At least I will use it for a period of about 5 days. I will give a simple broad spectrum antibiotic like a augmentin, amoxicillin. That's what I normally use. I will find out from Dr. Jensen and team what is the current protocol, what they follow here. I prefer giving an antibiotic for about 5 days, keep the patient on mouthwash for about a couple of weeks, and painkillers maybe for a day or two. After that, this is largely a painless procedure. Thanks, guys. Yeah.
When do we start the second surgery?